Okay, so this would be a nice example of an unfortunate patient. You might get called on in the middle of the night because their SATs have dropped, or they're having distress, or their ventilator is alarming. And let's walk through a couple of things that's wrong with this person. First of all, you know they're pretty sick because here's their endotracheal tube sitting up here, so they're probably in the ICU on a ventilator. The second thing I would notice immediately, other than the obvious, we'll talk about, and I always try to make myself not just look at the obvious. This is a skinny patient again, so who knows what's wrong with them, but maybe they have some COPD. They've got pretty big, long left lung here. But what your eye is drawn to immediately is the fact that the right lung does not look like the left lung. And the trachea is pretty centered, but this lung has significant volume loss. There is no delineation of the right hemidiaphragm. There's no delineation of the right heart border. Should be in here somewhere, right? There is no delineation, really, of much of anything past the right upper lobe takeoff, which I can barely see there. So, volume loss, pacification, minimal aeration is generally mucus plugging until proven otherwise. If this were someone who had a large pleural effusion that was obscuring most of the right chest, what you would usually see is not volume loss, but you would see expansion and pushing the mediastinum to the opposite side if it's something that's filling the chest. What's happened here probably is this patient's had a mucus plug in their right lower lobe, and they've lost their right lower lobe, they've lost their right middle lobe, because again, the right middle lobe abuts the edge of the heart, so you don't see anything here. So the middle and lower lobes are socked in, probably with obstructing mucus, and all you have left to be aerated is the upper lobe. The left lung looks pretty good. You can't see the diaphragm down here very well, but remember, this isn't a perfect film. It's a supine portable film, and you don't even have the edge down here, so they clip this person's edge. They may even have some atelectasis down here. We can't really tell. Now, the important thing about atelectasis is what are you going to do about it? If it's atelectasis because there's a mucus plug, then obviously you want to try to suck the plug out. And studies have shown that unless the entire lung is atelectatic, you can actually do chest physiotherapy, unless they have a bunch of broken ribs or are hemodynamically unstable. You can rotate this person to their good lung down and do chest physiotherapy and try to lavage and suction through their endotracheal tube, and you will have an equally good outcome to having an urgent bronchoscopy to try to lavage and suction this. So this would be someone, if you got called in the middle of the night, you could probably give instructions to the ICU staff to put their left side down, do some bed vibropercussion, do some manual vibropercussion, and maybe some lavage and suction. And if you're lucky, by the next morning, you might actually see some of this open up. If not, and the patient has respiratory embarrassment, you might need to do a therapeutic bronchoscopy.